Hello, everyone. For those of you that are just coming in, thank you so much for being here. My name is McMaster. Welcome to the Harnessing Evidence and Insights from Citizen and Systems Leaders to Spark Actions Towards Enhancing Access to AgeTech webinar. Again, my name is McMaster. I'm the Programs Coordinator at AgeWell. And for the Epic AT platform, I'm a white woman with short brown shaggy hair and green eyes, and I wear cat-eyed shaped glasses with a speckled blue, green, and white plastic kind of top at the top of them. And I'm wearing a gray shirt with a long green vest today. Before we begin, I just want to do just a few access points. So please note that today's webinar is being recorded and it will be available on the AgeWell YouTube channel after the event. There is closed captioning available if anyone that needs it. So if you would like to turn it on, please look at the bottom of the Zoom window and you'll see an icon with 2 C's that represents closed captioning. If you click on that, what will happen is everything that is being spoken today will be basically up here as a anonymized closed captioning with a black background and white text, but just know that it is automated, so sometimes there will be some inaccuracies. We do want to ensure that everyone has a good experience today, so for this reason, we expect everyone, all speakers and attendees, to show respect and kindness. And so if anyone is showing any form of harassment, please know that you will be removed. There will be a Q&A at the end of today's presentation, so feel free when that time comes to raise your hand using the Zoom feature, and then I can invite you to unmute to say your question, or you can share it in the Q&A icon, which is again just at the bottom of the Zoom window, or you can share it in the chat. But we do welcome you to share those verbally today. And please note that there are no anonymous questions in today's webinar. We do encourage you to use the chat, so share your thoughts, comments, and resources throughout today's presentation. And I will also be monitoring the chat, so like if you need to message me, feel free, and I can respond to any questions or concerns. And please feel free to share us where you're coming from today. Today I'm coming from Montreal, Quebec. So hello, everyone from across Canada. Before we begin, I do want to introduce Dr. Robin Tamblyn. This is a webinar that is actually inspired and works for our Epic AT platform, specifically a course that we have on policy and AgeTech, which Dr. Robin Tamblyn was amazing at co-developing with us at Epic AT. So Dr. Robin Tamblyn is a professor of medicine, a James McGill Chair and a medical scientist at the McGill University Health Center. She's a scientist of the McGill Clinical and Health Informatics Research Group. She was appointed Scientific Director of the CIHR Institute of Health Services and Policy Research in 2011 and served in this position until her term ended in December 2018. In 2005, Dr. Tamblyn received the CHSRF KT Award for Research in Improving Medication Use, and in 2006, she received the ACFAS Bombardier Award for Innovation in the Development of a Drug Management System. In 2014, she received the John P. Hubbard Award for Outstanding Achievement in the Assessment of Professional Competency in Healthcare and Medical Education, and she was appointed to the Order of Canada. In 2015, she received the Outstanding Achievement Award in the Evaluation of Clinical Competence for Sustained Excellence in Canadian Healthcare Research from the Medical Council of Canada. Dr. Tamblyn was selected as the 2018 Justice Emmett Hall Laureate in recognition of her outstanding contributions to health ideals, extolled by Justice Hall, and she was named the recipient of the 2018 Peggy Leatt Award in acknowledgement of her work in improving outcomes in Canada's healthcare system. And recently, in 2019, she was elected as a fellow to the Royal Society of Canada, and she was appointed Director of the Division of Clinical Epidemiology at the McGill University Health Centre. So I do want to thank you so much, Dr. Robin Tamblin, for being with us today and introducing Dr. Michael Wilson. Thank you so much, and I will see you all in the chat.
Okay, thanks everyone. So it's a real pleasure to introduce Dr. Michael Wilson, not to be confused with Wilson, which I did earlier this morning, I've got to say. So it's a real pleasure actually to have him here because he is actually the Assistant Director of the McMaster Health Forum. And if any of you have not heard of this, you really will hear a little bit from him today. It's really a world-renowned center where evidence meets policymakers, and it's a unique creation from McMaster, which was emulated by the European Observatory as a way of saying policymakers need evidence in order to create sound health policy. This was the forum that was created essentially to enable that to happen. So it's a pleasure that Dr. Wilson is here and is actually Assistant Director of that center. He's also Associate Professor in the Department of Health Evidence and Impact, and a member of the Center for Health Economics and Policy at McMaster University. His research has been focusing on supporting the use of research evidence for policymakers, especially in the area of AgeTech. So he's been part of the AgeWell Center of Excellence since 2015 and has been working in this space. So this is extremely timely, one of the very few people in this space in the country, if not internationally. He currently leads a CIHR grant focusing on strengthening evidence support systems in Canada, which complements his work and extends the work that he's been doing with AgeWell. And actually, he's the inaugural recipient of the Mid-Career Health Services and Policy Research Innovator Award. No big surprise, actually named after me, but I was like, that was gobsmacked over that issue. But I'm just thrilled to have him here. So over to you, Dr. Wilson.
Thank you very much, Robin, and thank you for having me here today to present some of the stuff that I'm working on. So if you can just give me one moment, I'm going to pull up my slides that I'll walk everyone through for the presentation today. So hopefully everyone can now see my slides. What I'm going to do, sorry, I'm trying to minimize the video. There we go. Okay. So for my focus today, as Robin was alluding to, I'm increasingly doing a lot of work in this area focused on strengthening evidence support systems, and I'll walk you through what I mean by that. But it's the focus that's come out of the Global Commission on Evidence to Address Societal Challenges that the McMaster Health Forum was the co-secretariat for. I have a link at the end to share with you, which has the update report that came out just a few weeks ago. It's been a year since the Global Commission was launched. So what I'd like to do is share with you some of the context and lessons learned from the Commission and some of our work domestically on that, the challenges we've identified in our work over the last year for strengthening evidence support systems in Canada, and some ideas for potential features of an evidence support system. So we've been deriving these insights through many interviews and analyses across the country that the CIHR grant that Robin just mentioned, for which I received the award, was funded last year. And then what I'm going to then do is walk you through just some highlights of some examples that we've worked on through AgeWell, where we used our efforts to pair evidence along with deliberations among citizens to identify their experiences and values and preferences for addressing these different health and social system challenges, and then also deliberations with system leaders that were focused on identifying actions that should be prioritized to address them. So just some quick acknowledgements before I go on. I've pulled a number of slides from the Global Commission on Evidence that I've been working on domestically, and a lot of these slides come from my colleague who I work very closely with, John Lavis, as well as the Global Commission on Evidence Secretariat, and who have developed many of these slides and that we use in many of our interviews that are continuing to go on. And then funding for a lot of this work is from my AgeWell platform grant that John and I co-lead, and then also the CIHR grant and the Mid-Career Health Services and Policy Research Innovator Awards. So very grateful for all those funding supports to make this work happen. So I'll start with some background on the Evidence Commission. So if you haven't heard of it, I'm not going to go in depth into the report, but last year when this was released, 3 implementation priorities emerged from the commissioners. The first was to formalize and strengthen domestic evidence support systems, and that's a lot of where my work right now is focused. It was also on enhancing and leveraging the global evidence architecture, and by that I mean things like global public goods that produce things like evidence syntheses that benefit many decision makers, that pull together the global pool of evidence, and ideally on a living way so that they're routinely updated. And then also put evidence at the center of everyday life. So that's to help citizens find and use evidence they need to inform their own decisions and advocacy. So I'm going to focus on the first one around domestic evidence support systems. And here our Secretariat and its partners in 12 different countries right now are conducting what we're calling rapid evidence support system assessments, or RESAs, and sharing lessons learned through our country team leads group. So the goal is in each country is to identify what's going well that needs to be systematized and scaled up, and then what gaps need to be prioritized to fill, and then to work with government policymakers, organizational leaders, professionals, and citizens to push for improvement. So I'm leading along with John the work in Canada, and then the Global Commission is coordinating the work in the many other countries. So what do I mean by conducting one of these rapid evidence support system analyses? It starts with an understanding of what we mean by an evidence support system and what that is. So I'm using that to refer to many types of infrastructure, and this could be things like structures and processes on the evidence demand side. So the people who need evidence to inform decisions, and that could be structures or processes to incorporate evidence into routine advisory and decision-making processes. So to make the use of evidence part of the everyday processes that are happening. Also building and sustaining a culture for using evidence to make it the norm within these processes to look to and to use evidence to inform those decisions, and then to strengthen capacity for evidence use. So having also the skills in place to do it. It's also the mechanisms at the interface between those who are in need of evidence, the evidence demand, and those who can supply it. So the people who produce different forms of evidence to work together to elicit and prioritize the evidence needs of decision makers and their advisors, but also package that evidence from many different sources, so not just one form of evidence, and to align it with advisory and decision-making processes. So that interface to join things up. And then the last piece are evidence support units, and this could be in-house within governments or partner organizations on the supply side that are timely and demand-driven. And by that, I mean responsive to the needs of decision makers and providing responses based on the best available evidence within short periods of time or in the timelines that those decision makers need it, rather than on research timelines. It's also about focusing on contextualizing the stock of the existing evidence that we have, and that can be both domestic, so the things that we know in Canada, but also pairing that with the global evidence for a given decision, and also always with an equity sensitive lens. In comparison, so we have very well developed research and innovation systems. So by research system, I'm talking here about those systems that focus on creating generalizable knowledge and that are often measured with success through things like peer-reviewed grants and publication systems. And in AgeWell, we know the innovation system particularly well, which is focused on commercializing products and processes and to measure success with revenue. So we have a well-built up innovation system, a well-built up research system. So our goal is to say we also need to similarly strengthen our evidence support systems to get that evidence in front of the people who need to make decisions. So I'll just walk through a few key highlights from this. I just want to give you a sense of our methods for doing this and conducting these evidence support system analyses. So we're drawing on, and this is supported in part through our CHR grant, and through AgeWell, in Canada at least, drawing on websites, documents, as well as interviews with senior policymakers in many different policy domains across the country. So not just health, but also central agencies as well, to find out what's going well and what needs to be systematized and scaled up. So if we're talking to people on the demand side, we're asking them the kinds of decisions that are made and what does that mean for the types of evidence that they need. what sources of evidence are currently drawn on, and what enablers do they have in place. So whether it's standards for evidence use in cabinet submissions, budgets, or something else. If we're talking about demand side coordination work, we're asking them, are there people who have experience with things like horizon scanning to identify priorities that are likely to emerge, and with prioritizing and scoping questions and decision making? And are the questions typically similar to those being asked by other groups? And is there a mechanism in place to share those questions and responses across groups? So more of an integrated response to avoid that duplication of effort and waste in research dollars. And then, are the questions typically complex and they require engagement of multiple evidence support units? On the supply side, we're asking people, is there anyone who can act as a general contractor and bring in the right trades or forms of evidence depending on the question? So in the policy and system world, these are typically policy and systems researchers. And by general contractor, we're using that as a metaphor for someone who kind of has a big picture view of what a decision maker might need and may not be the expert in all the forms of evidence that might be needed, but can certainly work with all those trades to be able to pull together an integrated evidence response for the decision maker's needs. And then for behavioral changes among professionals and citizens, we're often looking to people who are in the space of behavioral and implementation research to lead that kind of work. And then we ask, is it possible to provide integrated responses that could take the form of one or more of an evidence scan or a jurisdictional scan, horizon scan, interviews, or deliberative processes? And that's the second part of my presentation, where I'll give you some examples in AgeWell about how we try and pull together those integrated responses with deliberative processes. So I'm just going to move into a few key slides from the Global Commission around lessons learned from the COVID-19 pandemic about evidence support. And the first is that through all of our work with a group called COVIDend, which is the Evidence Network to Inform Decision Making, what we found is that we just can't continue to allow a low signal to noise ratio in evidence support or in evidence supply. So we house an inventory of the best evidence syntheses in the world. And when we analyzed it, we found that not only is there an imbalance in the types of areas that were the focus of best evidence syntheses in the world, but so with many on clinical and very, very few on economic and social responses, but also within each of these domains, many were very low quality evidence syntheses and quickly became out of date. So there needs to be a focus on balance as well as producing higher quality syntheses and keeping them up to date and reducing the duplication of work. The second lesson is that we can't continue to respond to policymakers' questions with select forms of evidence instead of the right mix, and focusing on things like preprints, squeaky wheel experts, or old school expert panels. So during the pandemic and continuing now, we often hear lots about things like data analytics and modeling and evaluation, and often very little about other forms of evidence that need to equally be considered in policy cycles to inform decisions. And in addition, things other than best evidence are often considered. So we often hear very much about single studies or preprints that haven't necessarily been appraised for quality or placed alongside other studies addressing the same question. We often hear from experts who might not be talking in a way that would make it possible to assess their accuracy. So they're not backing up their statements with evidence. We're often hearing from what we call old school expert panels that generate recommendations where the intersection with evidence is very unclear. And we're also having engagement processes that don't provide ways in for evidence. So needing to rethink the balance and how evidence is inserted in many different ways. What we did see, though, were a number of different innovations for evidence support. So one is ultra rapid evidence support. So this recognition that it can now work at the same speed as a policy process. So 1 to 10 days, for example. As an example, our group at the forum and in COVIDend, we're routinely doing quick reviews or evidence profiles that would scan the best available evidence, complement with a scan of experiences in other jurisdictions in 1 to 3 days in response to very, very urgent questions. Sometimes also doing things like horizon scanning to identify priorities, and then also sometimes complementing with interviews to identify insights from those actively working in the field or engaging in deliberative processes to generate those lived experiences. We also know that evidence supply coordination can be used to leverage all needed forms of evidence. So that general contractor role who can work across different forms of evidence and pair that also with global evidence to pull together these integrated responses. We know also that one-stop shops for evidence syntheses are key. So to know that there's one spot where the best syntheses live in the world, and you can go and find something in a matter of minutes if you need to and have it quality appraised is fundamental to be able to mobilize this kind of support. And the last piece is living evidence syntheses. So this here we refer to things that are, you don't just do a systematic review, but you commit to updating it on a routine basis. So for example, our group coordinated a living evidence synthesis about the effects of the COVID-19 vaccine, and it was updating every 2 weeks. I think we had something close to 50 versions by the time we ended up finishing it. And there are several other such examples where the commitment to routinely updated means timely evidence support. The other piece here that I'm just going to flag under context is just the understanding about what an evidence support system needs to do. So if you're thinking about, okay, what does a general contractor in this sense need to do? We're talking about first understanding the cycle and the stage in the policy cycle. So decision makers need to understand a problem and its causes, figure out options for addressing that problem, identifying how to implement it, and then monitoring and evaluating to identify what else needs to be done. So if you're looking at a problem and its causes, you're matching the best forms of evidence, which are often data analytics, modeling, and qualitative insights. But when you move to selecting an option, the best forms of evidence are modeling to figure out what might be the impacts of something, or evaluations to identify what are the impacts of doing something, and qualitative insights to understand the acceptability of it. And then moving to implementation, you're thinking about behavioral science type work, again, qualitative insights. And when you come back to monitoring and evaluation, data analytics then becomes very important. In our talks with policymakers, there's an inordinate focus on data analytics lately, as though it can inform and solve all the different stages of the policy cycle, but in reality, it's very helpful for stages 1 and 4. And then going further from that, thinking about the local level of those forms of evidence, it's also about comparing it with the global evidence with evidence syntheses, and then thinking about how we generate recommendations and thinking about things like technology assessments and cost effectiveness analyses and guidelines. And the last bit of context before I move on to some what we've found is that another way of thinking about this, and this might be language you've heard in the past, are using cycles of rapid learning and improvement. So here, if you have 3 stages, the first one is making sense of the market and the population, and then prioritizing. So you're identifying things like what are the gaps and what's driving them, where are the inequities, what kinds of priorities need to be addressed, and then you're looking at things like analytics, modeling, and qualitative insights, and/or syntheses of those forms of evidence. Then in that cycle, you're then moving on to co-designing new services and service models. And here you're asking about what evidence-informed solutions exist, how will those solutions be adapted or designed for system communities and system users and communities. And here again, you need evaluation and modeling to identify what we know about those solutions, as well as the qualitative insights, and ideally the global flows of evidence from evidence syntheses and technology assessments. And then on the last stage of the cycle, you're asking to implement and then adapt using system level monitoring and evaluation. Does the model work? How and for whom? What adaptations are needed to cement and scale? So if you think about this from the innovation stuff that AgeWell does, this kind of cycle is of critical importance, that it needs to be ongoing and using different forms of evidence to identify what can and should be scaled and what do we need to do to adapt as we go. So I'll walk you through a few insights that we've heard from many interviews we've been doing both at the federal level as well as in many provinces and territories in the country about the challenges for strengthening evidence support systems. The first is that there's unevenly distributed capacity. And this is what we've been hearing from people we've spoken to. There's this general hollowing out of policy capacity in the public service, where we have frequent moving of staff to different areas of the public service, focusing on immediate issues rather than long-term planning. Sometimes capacity being centered in political offices as opposed to the public service. An uneven awareness of foundational concepts. So what does evidence versus expert opinion mean? What are the different forms of evidence and how can they be matched to policy questions? The need to combine global and local evidence, and that peer review is not a proxy for quality of evidence. It's also this uneven awareness and use of available policy supports, Some groups tending to assert that we do all of this already. And, there's a lot of things that we're talking about. And I find it's very hard to imagine any group that's doing all of this work already. So we're trying to be big picture here. And then a lack of fit for purpose capacity building that makes sure that the skills are in place to be able to do this kind of work going forward. We're also hearing about an unevenly supportive culture, and a lot of groups talking to us about that there's the assumption that evidence support in the way I just described still can't work at the same speed as policy processes, despite many issues being known for a long periods of time. This leads a lot of governments to engage consultants and or processes that aren't always engaged by the best available evidence. And that means there's a risk of being called out on low quality processes or suboptimal results. And also a lack of commitment to transparency, which means we often turn to expert-driven decisions rather than the best available evidence, and a growing risk of being called out on that. Also, the last piece we heard on the demand side are these insufficient enablers to support evidence use. So things like few explicit requirements in cabinet submissions or budget proposals, spending submissions and briefings, not inserting methods expertise into stakeholder panels and expert panels. So that means having someone who's there who can also synthesize evidence, judge its quality, and use that as another input into those panels to generate recommendations that are formed based on expertise and on best available evidence. Not using things like evidence prioritizing processes, coordinating evidence and supply demand, not evolving our standards for evaluation beyond just two forms of evidence, the data analytics and evaluation, and not having standards for evidence synthesis or agreed upon lists or one-stop shops for that evidence. And then we're also hearing lack of evidence-attuned human resources process that emphasize that importance of the general contractor who can pull a lot of this stuff together and put those integrated responses together. So challenges when we talk about the interface of evidence demand and supply is that we hear from a lot of groups that there are separate requests coming across governments for evidence, different groups in the country, within provinces, and then separate responses coming from official organizations, from consulting firms, from other service-oriented national, provincial, and territorial groups, and global evidence architecture. And so that means that we don't have integrated responses. It also means that we have a lack of coordination of evidence responses and a huge amount of waste in the production and support for evidence, rather than joining up and coordinating to be able to make the best use of the resources that we have. When we move to the supply side, what we hear in terms of challenges are uneven coverage of the 8 forms of evidence that could be used to support government. So we have relatively few units identified for evidence synthesis and behavioral insights. And here we're talking about timely demand-driven units for evidence support. And there are many units for data analytics, modeling, and evaluation. So the idea is that we need to also invest in the other forms of evidence that need to be available in a timely demand-driven way. And uneven availability of those supports across government areas. So there is some significant infrastructure in health and finance, but less so in other government ministries and government service areas. So in AgeWell, yes, the focus is on health, but often it's intersecting with many other government areas as well. And that infrastructure needs to be in place. Also hearing the mix of standards for things like the forms of evidence, the standards for what's included in different types of responses to decision makers, and not having a roster of service-oriented evidence support providers, or providing a common approach to describing and adjudicating our calls for evidence support. And then lastly, around public sharing. If we don't have public sharing of responses, then it's going to be impossible to also coordinate and integrate our responses because we don't know what's available. So I'll put this in front of you as well before I change gears a little bit to some of the examples of the stuff that we've worked on with AgeWell. And this is our figure that we've been working on to say, what are the potential features of an evidence support system? So at the top, you've got government policymakers and central agencies, again, line departments and legislative bodies with separate or shared evidence demands. And then in the middle, you've got this evidence demand coordination. So what we've called one window requests, when they're complex questions, to have one mechanism for these complex questions to try and coordinate all the evidence needs in an area, and then liaising with an evidence support network who can provide that general contractor role to say, for this request, we're going to need data analytics. We're also going to need evaluation and some implementation research, some qualitative insights, and ideally some syntheses from the global evidence architecture on the bottom right. And then once we've got all these in place, we're going to these different nodes of timely demand-driven evidence support. That support network is then going to develop an integrated response that pulls together all those forms of evidence and meets the needs of those who need the evidence in the end. But what we're hearing when we put this in front of people is that most jurisdictions have few of these features, and even fewer are working optimally, especially when crises emerge. And we want to make sure that we're as prepared as possible for the next future crisis, so that we can continue the work put in place to be able to support timely decision making especially when crises emerge. We also are hearing that there are several leading edge groups in government, but generally we suffer from this hollowing out of our policy capacity and a failure to keep up with new developments, and also relying on in-house staff and few management consulting firms, but no mechanisms to get the right questions to best-in-class and service-oriented evidence support units and incorporate those insights into policies and programs. And then lastly, what we're hearing is that we do pretty well with data analytics, somewhat well with evaluation, and very poorly with the other forms of evidence. So we are continuing to road test all these ideas. The slides that I've presented you here are very much an iterative work in process, and we float these to the people we're interviewing and adapt as we go. So with that, I'm going to take just a few more minutes, maybe 8 minutes or so, to walk through our approach to harness evidence to inform deliberations among citizens and system leaders. So back on one of the earlier slides, I talked about this notion of kind of that contextualizing work to try and integrate evidence and many forms of evidence as alongside other types of evidence support, like through deliberative processes, for example. And this is what our group at the forum has been doing for many years now. And we started doing stakeholder dialogues. That was one of the first things that the forum in 2009 started with. We then complemented with what we call citizen panels that are designed to have deliberations with citizens from all walks of life to identify experiences and values and preferences, and to use those findings to feed into the deliberations with system leaders in those stakeholder dialogues to identify actions, and based on the best available evidence, based on what citizens are saying, and then hearing from the experiences on the ground with those who are leading the system in which that's affected by the issue that they're deliberating about. So our logic model is such that we always identify with a need, so expressed by a policymaker or a stakeholder within a health or social system, and they want best evidence, citizen values, and stakeholder insights. Our assumption is that we're working from that evidence and the values and the stakeholder insights about a problem, options to address it, and implementation considerations, and that's being used to provide our process, to inform our process, and being attuned to different policy processes, political sensitivities, and health and social system realities. So this is this contextualization piece. What we do is then we work with our partner and sponsor, we convene a steering committee. We work with our staff at the forum who has a lot of expertise and experience with this. For our panels, we work with an online market research firm called Asking Canadians to recruit panelists for all of our panels using recruitment criteria, sampling criteria that we're looking for. So it could be citizens from all walks of life, or it could be citizens with particular lived experiences as well, and they help us recruit based on their panel of almost 1 million Canadians who are diverse across all of the StatsCan categories. And then we engage merit reviewers to review all of our documents before they go in front of the eyes of citizens and the system leaders being convened. To do this, we're consulting with our steering committee as we go. We're preparing an outline of these briefs. We conduct key informant interviews to identify and refine our framing and the types of things that should be considered. We're recruiting our participants with our steering committee and our online market firm. We convene the panels, we prepare the summary, and then we put that in front of the system leaders coming for the stakeholder dialogue. And then our outputs end up being, for these joined up processes like we do for AgeWell, a plain language citizen brief of the evidence about a problem, policy options, and implementation. a high-level summary of those deliberations, and then an evidence brief that also incorporates those key findings, a thematic analysis of the deliberations, and then we put together things like video interviews and our communication, so active dissemination to get this out. So three key examples I'll just put in front of you for things that I've worked on with AgeWell. And the first one was around enhancing equitable access to assistive technology. So we published a paper in Healthcare Management Forum in the fall based on some of this work. And so the challenges we identified, and I'm just giving you a snapshot of the very high level findings from these products. There's papers and reports from each of these, but the challenges we identified from this project that convened panels and 2 different dialogues actually is that system level complexity can make access to and navigation of programs for assistive technologies very challenging and result in inequitable and inconsistent access and therefore unmet needs. They also said that the values and principles guiding current policies and programs for assistive technologies are not aligned with those of the citizens who use or can benefit them, who often very much value flexibility and the need to customize based on each individual's unique needs, and that policies, programs, and practices are not keeping up with increasing need for assistive technology and the rapid pace of advancement. And then lastly, the lack of a guiding policy vision to support those actions across the country limits coordinated action to enhance equitable access. And so that last one was what led us to do a follow-up set of deliberations with system leaders about thinking about what would be included in a policy vision if it were to be developed. And this is the figure from our paper. What matters here is that a few top priority issues emerge from these deliberations. One is that we have an unclear definition of assistive technology, which makes the sector confusing. There are many barriers that are driven by financial barriers, complex system navigation, and complex choices faced by consumers, and an overall lack of focus on environmental accessibility. To address this, what we heard in our deliberations is that the principles that underpin policy action need to use a human rights-based perspective where everyone's entitled to equality, dignity, respect, and freedom of dissemination, and a person-centered and co-creation approach. And then the group identified 3 short-term and 3 long-term priorities for eventual policy vision. So adopting a common language for assistive technology, making sure the consumer experience is streamlined to make sure they can more easily navigate the programs that support access to assistive technologies, and minimizing coverage gaps and financial burden on consumers. In the long term, the focus is on making access to those technologies fairer for people who often face the biggest challenges, ensuring that environments are designed to be accessible by people of all abilities and that those goals are consistently supported through policy, and improving knowledge and skills of all professionals who are involved in this. So that's the snapshot of that program. The one that we also recently published in Healthcare Management Forum, it was a special series in that journal through AgeWell, was around identifying and harnessing the potential of tech in long-term care settings. So here, the focus was that through the pandemic, as everyone knows, affected those in long-term care in Canada much more than others. And there was an identified need at the time to harness the potential of technologies to help address some of the biggest problems being faced in long-term care then and into the future. And with governments moving to address many of those concerns, we sought input from citizens and citizen leaders about how to do this. What we heard from citizens, and again, this is just a very high-level snapshot, is that there were a number of challenges from their point of view. Some noted that fundamental issues with long-term care need to be addressed first before we can even identify and harness technologies, that there are so many fundamental problems that have been at length covered in the media and in reports since then. There's also just the sense that overall long-term care homes don't take advantage of technologies that are out there. And there's many examples in the report that is out there if you're interested in reading up more on it. They also pointed that the uptake of technologies, if not supported across the system, could further increase inequity in long-term care in the sector. It's going to be still more about who is able to pay versus those who are in need. And also concerns about relying more on technology could reduce human contact. So they didn't want technology to replace the human contact that is so important in long-term care. The persistent myth that older adults are not interested in or able to use tech, and community resources and infrastructure are either not optimally leveraged or are lacking. In addition to those, the system leaders and the stakeholder dialogue talked about kind of a lack of a comprehensive innovation agenda for long-term care, to say it's not only enough to say we need to reform long-term care, but we also need to put an innovation agenda in place to say our vision for this, for a reformed and kind of long-term care of the future, what does that look like? And then residents, families, and caregivers are also rarely and inconsistently prioritized and meaningfully engaged in either reforms and/or technology development. And as a result, it's often not attuned to individual needs of residents and local realities. And as a result, also, the long-term care sector is just broadly viewed as not an innovative space, and the value of technology is often questioned. So a lot of things in place that are making it difficult to really harness the use of technology in long-term care when there's much potential for it. And so the next steps identified by system leaders in our deliberations were to prioritize a co-design approach at all stages, identify and coordinate existing innovation projects to enable that scale and spread, and use technologies in a way that enables person-centered care and support in long-term care. Prioritizing that kind of rapid learning cycle. So that came up very strongly, to use small yet rapid changes that are centered on residents, caregivers, and families, and evaluate and change over time. But then the need to pair that with funding models that also need to enable the flexibility needed for those types of rapid learning cycles. You can't change things, evaluate, and change without funding that flows in new ways to support that as well. And so lastly, this is one we just finished in December. So we held these deliberations at the beginning of December around using remote monitoring technology. And so I'll wrap this up very quickly so we can go to questions. So this is one of the figures from the brief, a snapshot of remote monitoring technologies. We're asking who are the potential users, what can be remotely monitored. So things like health, wellness, home environment, the types of technologies, make some examples of them. So sensors, cameras, wearable devices, handheld devices, smartphones. This is a massive area. When we actually took this on, we were taken aback by the breadth of the field that we had taken on and the sectors that could be integrated with this as well. And when you think about it, the many aspects of an individual's health that can be monitored, so things like breathing, heart rate, body temperature, oxygen saturation, but also many aspects of a person's overall wellness and home environment that can also be monitored. So this was the scope of the brief. And so what we wanted to hear from citizens and from leaders was about what makes it challenging. And so citizens identified 10 challenges that those in the stakeholder dialogue largely agreed with. So a lot of lack of public awareness about remote monitoring technologies and how it can be used, that it could raise also concerns and fears. So being under surveillance, the costs with it, uncertainty whether there's a threshold to use remote monitoring technologies and when it's cost effective, privacy concerns, divergent views about the protection of personal data could be hard to reconcile. It's hard to navigate what technologies or services are available, concerns that the technologies will replace human contacts, needing to ensure the validity and reliability of the many technologies that are out there, and attitudinal barriers make it hard to innovate. So this unwillingness to step outside of the box in the system to be able to adopt some of these new ways of doing things. So when thinking about that, the leaders said there are 3 key next steps. The first is to help clients and families get excited about remote monitoring technologies. And one person in particular talked about the need for conducting person-centered and empowerment-based assessments, making it more of a brand around fun and engaging lifestyle perspective. And then also using that to drive modernized approaches. So it could be that things like remote monitoring are anchored in community pharmacies, especially for people who are unattached to primary care. And that can be their link to the system, especially where there's limited primary care available. And again, engaging in those rapid learning and improvement cycles. So I'll leave it there and we can open up for questions, but just as a sense for next steps, we're continuing to work on these evidence support system analyses. We're going to be convening a national dialogue with champions around strengthening evidence support systems, and I'm hoping to convene another set of citizen panels and a dialogue around this idea of joining up innovation, research, and evidence support systems. So that's the direction we're taking. So I can leave it there, and then I can happy to take questions.
Thank you so much, Mike, for that. That was so great. Thank you so much. Maybe just so moving forward, if anyone has any questions, feel free to raise your hand. You'll see the kind of raise hand icon. It looks just like a hand like this at the bottom, and I will unmute you. You are also invited to share your questions in the chat. I know I have a few questions about this amazing content, so we'll give a minute just in case anyone wants to have a question. In the meantime, so this is a very new territory for me. So I wanted to know, Mike, more about the citizen panels, actually. Could you talk more about just like some of the challenges of creating those, especially with older adult stakeholders, and like some of the maybe some tips that you can offer to people that are new to this process?
Yeah, great question. And so it's one thing I would have liked to focus on more, so I'm glad you brought it up. So there's a couple ways to frame the challenges for citizen panels. I think there's many in doing this kind of work. And the first is with recruitment. And to do panels, we really had a commitment to make sure that we could recruit people in a very systematic and transparent way to make sure that we weren't just recruiting kind of the people who are usually around the table. And it's great that we have lots of involved kind of citizen partners in AgeWell and in other groups, but we also just want to cast the net so much wider and just hear from people from all walks of life. So really the only way we figured out to do that was to work with this marketing recruitment firm called Asking Canadians. And so the hook for that group is that they administer, everyone is connected through some sort of a rewards program in the country. So it's people who are somewhat connected online to an extent. So there's a little bit of bias that way, that they're people who are connected online. But then what we're able to do with them is to say, okay, we're convening a panel, let's say 15 to 16 people. It's focused on remote monitoring technologies with a lens on aging. What we want are some older adults who may or may not have experience with any of this, but who might need to think about this in the future. We want to talk to some caregivers who might support older adults in that process and might be the ones managing that kind of technology. It could be just others who haven't had any experience with this, but might have an interest in it at some point. And so they'll go out and recruit through their network to find those kinds of people to us. When we give them age breakdowns, we want a relatively balanced age bracket on the panel, ethnocultural background, areas, so urban, suburban, rural. And then we do panels, like for this one, I think we did 4 or 5 panels. So they were in different parts of the country. So we had people from Western provinces, we had Central, we also ran a French-speaking panel. So I think that's the key thing. So that's one of the things around challenges for recruitment. The second is the writing of the brief to inform the panel. So it's some of the most challenging writing that I probably do, to take all these different forms of evidence, package it in a way that's relevant to people, to citizens who might have an interest in this from just a lay perspective in everyday life, but to convey that evidence in an interesting and compelling way for them that they can understand. And so, we certainly have not perfected this. We're continually trying to innovate in this space. We've really taken it back and tried to simplify as much as we can. Use infographics, we use some text to support it, mostly in bullet form, and then also embed spaces with questions that we want to ask them during the panel, and then space for them to jot down notes, because they get the panelists get the brief about a week in advance. So we ask them to have a read through it if they can, jot down some notes, jot down some questions, and come prepared for that panel. I'd say the third challenge now is, how do we work this in a virtual world? And what are the benefits trade-offs of online versus in person? We used to always do these in person. We'd pay for their travel to come in. Of course, during the pandemic, we did all of this virtual. It gave us the ability to reduce costs substantially, but it also took away from some of that in-person dynamic you have as a facilitator and a group dynamic you have when people are in the room. It also created some connection challenges for people who might not have super fast enough internet speed. And perhaps if people are less than familiar with virtual platforms like Zoom or Teams, makes it challenging for them. So it's a very difficult space to wade through right now, because I think there's a lot of methodological choices to make, and I think we just need to continue to experiment and think it through in a meaningful way.
Thank you so much. That was like so informative. We actually have another question from the attendees, from Emily Gauthier-Beaupré. What are some challenges you encountered in engaging with system leaders / policymakers?
Yeah, so this is a good question as well. And so I think it's different challenges with them as compared to the citizens. So you have people coming in who are very much experts in a particular area. So let's say this remote monitoring group, we're going to pull in people who are, let's say, advocates in the caregiving world. We're going to pull in people who lead policy portfolios at the assistant deputy minister level or director level in provinces for things like continuing care or health system innovation, a whole variety of things. And you've also got other interests around the table. You've got citizen leaders sometimes around the table, researchers or other groups who are keen on one technology maybe versus some others. So the challenge is that, to say, do you aim for consensus on some of this stuff, or do you aim for having a very fulsome discussion and airing of like the really important issues from different perspectives, viewpoints on what can and should be done? And so we go that route. So we say we don't aim for consensus, because it can be very hard to achieve with that. But the idea is that we're bringing people in from different perspectives and who can well poised to champion change, but bring those unique, innovative insights about the issue. And so the challenge of it as a facilitator, because I facilitate many of these, is to ensure that not one or two perspectives dominate that discussion. And so that really requires, or I should say, brings it back to the importance of that evidence brief that we put in front of everybody before they come, to say, here's where our starting point is. Here's the evidence, the best available evidence we're able to find. We've packaged it based on what's driving the problem, some options that we've heard from key informants that should be on the table, and from government partners, and implementation considerations. And so everyone's coming from that same starting point, what the evidence says, and they're bringing those views and experiences together for a very fulsome discussion. And we do so, I guess the other part of that, we do so using what's called the Chatham House rule, where you've got sometimes very high level people around the table. So everyone needs to feel free to be frank during those discussions and forthright. And so we say people are open to sharing ideas and content from the deliberations, but not attributing it to an individual, because you don't want an assistant deputy minister or deputy minister having something attached to them in the paper the next day. So sorry, long-winded answer, but there's again a lot of moving parts with that stuff too.
Thank you so much. I do encourage people to continue sharing their questions. Please feel free to raise your hands, and I can unmute you, or you can put it in the chat or in the Q&A. As we're waiting, I guess, again, I'm very new to this process, so I probably have lots of questions. But I'm really interested also, you talked about steering committees. Can you talk more about how should we consider who should be on those steering committees, and how do you seek to get people on those steering committees, and what role do they play?
Yeah, that's a great question. So for each of these processes, you're right, we convene a steering committee, and that steering committee, we try and focus on having people that are on the evidence demand side. So those who have identified the need for not only the evidence, but also the insights from the citizen deliberations and the stakeholder deliberations, so that they can help shape what the evidence demand is and what the policy demand is ultimately, so that we can ensure that the process is as attuned to policy processes as possible. So we'll often have some of our government partners on the line, so working in the bureaucracy, who are kind of managing a policy portfolio. We'll also reach out to people working specifically in the area who can offer content expertise as we go. So in remote monitoring, we had people around the table who work in that space and think about it all the time. The idea is that it's an interdisciplinary group. With these kinds of complex questions, there's no way that me as an individual could possibly shape all of these projects on my own. That's part of the nature of doing policy-driven work with complex questions. You need to work in these interdisciplinary teams. So that's the approach to do it. So decision makers who are demanding the evidence, plus expertise, and then plus some maybe stakeholder representation on the group. It's like probably 5 to 6 people, and we meet with them 5 to 6 times over the course of a project, put key documents in front of them at different junctures of the project. They read, provide feedback. We have a generative discussion. So it's very much an iterative process.
We actually have time for one more. So Bern, I'm going to unmute. It's Bern Evans, actually one of our AgeWell OAC AC members. So Bern, if you just want to unmute yourself, you're going to be able to talk.
Got it. Thank you.
Yeah.
Michael, first off, I'm really enthused about the principles behind the evidence-based decision-making. As an aside, you mentioned 7 pan-Canadian health organizations. I'd like to know who they are, but we'll do with that through Ash or something later. What I'm concerned about is that in looking at evidence-based decisions is all of the good work that's done, say by you and your colleagues in the various organizations, in general, run into government intransigence. And by that, I'm looking at the political people that in effect put the final stamp on decisions suggested by their staff. The staff is usually or often well informed, knowledge, trained, PhDs, whatever, but they still have to have many of their decisions okayed at that government level. And that government level is, happy to govern for the first 2 or 2.5 years of their involvement. And then they're busy worrying about the next election and could give a damn about what's coming up the system in terms of decisions. And it seems to me over and over and over again, we who are involved in this area run into a lack of any kind of long-term policy thinking at the government political level. And I think of Quebec and the horrible damage that was done in long care systems in Quebec in the early parts of the pandemic. But that's just one simple example of, I call it government intransigence. They don't set the right policies, and well, I'll stop there. I could go on for hours.
Okay, thanks, Bernard. It's a good question. So, and one that I often get asked in these kinds of presentations. And one part of my answer is that all of what I talked about is nested within the acknowledgement that policy decisions have to take into account many factors, one of which is evidence, but it also has to account for different institutional constraints, how you work with other governments within the Federation, brokering with interest groups, public values, all sorts of things that political decisions have to consider. And so my perspective, and I think that, a lot of the things that you said were valid around, priorities and decisions and when things are done. What we're trying to do with the evidence support work is say, within that context, we can do a far better job of trying to think about how we strengthen our evidence support mechanisms so that when a decision is on the table or when there's a demand for evidence, that it can be responded to in a robust, integrated way that balances the different forms of evidence and does so in a timely and integrated response. So I think that's my short response to it. We could probably talk at length about some of that stuff, but yeah, so thank you very much.
Thank you so much, everyone. I think we're gonna, my partner just made a cameo. Just talking about remote working, right?
Yeah.
I do want to thank you so much, Michael, for this very informative and just dynamic discussion that affects so many of us, and so many tools that you shared for many of us that are new to this discussion. So I really want to thank you all. Please check us out, AgeWell socials, which I've posted in the chat. This will be available on our YouTube channel. And thank you so much. And have a great February 14th, everyone. Thank you so much.
Thank you.